Hello, everyone. Today, we will study the common disease in cardiovascular system, arrhythmias. So today, we will study antiarrhythmic drugs. Before we study antiarrhythmic drugs, let's know something about arrhythmias. The definition of arrhythmia means cardiac arrhythmias arise from abnormalities in impulse formation and impulse conduction due to alternation in activity of sodium, potassium, calcium channels of cardiomyocytes. From this definition, we know the meaning of arrhythmias means impulse formation abnormal or impulse conduction abnormal and induce arrhythmias. Arrhythmias also due to alternation in activity of these channels, such as sodium, potassium, calcium channels. Therefore, effects of antiarrhythmic drugs on ion channels activity are basis for their pharmacological application. So that also means later we will study antiarrhythmic drugs. They are sodium, potassium, and calcium channel blockers. We divide arrhythmias into two broadly categories. Few patients, they are bradycardia. Means bradycardia, their heart rate less than 60 beats each minute, and we call these patients they are bradycardia. Bradycardia also includes sinus bradycardia and conduction blockade. Sinus tachycardia and bradycardia conduction blockade also divide into three stages: mild, moderate, and serious patients. First and second stage. The first stage, mild bradycardia, mild conduction blockade, means the patient's heart rate from 60 to 50 beats each minute. And some patients, they are young, healthy patients, so not very serious. They are mild or normal. Second stage, moderate bradycardia, moderate conduction blockade, means the heart rate from 50 to 40 beats each minute. And these patients, they are second stage, and we should use some drugs to treat these patients. The third stage, serious patients, means the heart rate less than 40 beats each minute. For bradycardia and conduction blockade patients, in fact, the best therapy, we should suggest the patients use electronic pacemaker and not use drugs. But if some patients, they are elderly patients or they are mild patients and they want to use drugs, bradycardia and conduction blockade, the first choice agent is atropine. We also can use isoprenaline. We have studied atropine in M receptor blocker. So today we study how to treat arrhythmias, means we study the second kind, tachycardia. Most arrhythmia patients, they are tachycardia patients. The heart rate more than 100 beats each minute. Tachycardia also divided into several kinds in accord with the different formation sites. The first one we know, if here sinus node tachycardia, we call it sinus tachycardia. And here are left and right atrium. Left and right atrium, this atrial arrhythmias also includes atrial premature beats, atrial tachycardia, atrial fibrillation, and atrial flutter. Here is the AV node. if the arrhythmias are formatted from here, AV node, and we call this arrhythmias is the paroxysmal supraventricular tachycardia. And then here, ventricular Purkinje fibers. So if the arrhythmias occurs in ventricular, we call this ventricular arrhythmias. Ventricular arrhythmias includes premature ventricular contraction, ventricular tachycardia, and ventricular fibrillation. Most tachycardia patients, most arrhythmias patients, they are tachycardia. So we mentioned the arrhythmias patients means tachycardia patients. Later we study antiarrhythmic drugs means we study the drugs to treat arrhythmias, to treat tachycardia. This is the atrial flutter, and the atrial beats very fast, nearly 300 to 400 beats each minute. And then this one is the atrial fibrillation, very, very fast. And the atrial beats more than 450 and very fast. This is atrial fibrillation. And here it is the ventricular fibrillation, the most dangerous arrhythmias. And this ventricular fibrillation, the death rate nearly more than 60%. So the most dangerous. And this one is the ventricular tachycardias ECG. And this is very fast. It is the ventricular fibrillations ECG. Before we study antiarrhythmic drugs, we should review some knowledge we have studied in physiology. So let's review the electrophysiology characteristics of cardiomyocytes. And we should know one heartbeat, one action potential of cardiomyocytes is formed from here. We call it sinus node, and then conduct to atrioventricular node, and ventricular Purkinje fibers. One action potential, one heartbeat. Okay. And we know RMP is resting membrane potential. Compared to RMP, when the cardiomyocytes, the voltage to 70 from 90, this is 90 MV, and 10 into 70, 70 MV is the threshold potential. Lead to threshold potential, TP, and then have one action potential, one heart rate. Action potential also divided into different phases. The first phase, phase 0. Phase 0, we call phase 0 is rapid depolarization. Intense involved current of sodium flowing when the membrane potential reaches the so-called varying threshold. Phase 0, this period, and just now we have known the major channel is sodium channel. Sodium channel is opening, and then the sodium flowing in. We call this rapid depolarization, phase 0. Phase 0 determine conduction, while determine excitation. We have explained sodium channel is the major channel in phase 0. So that means sodium channel determine conduction velocity, determine excitation of cardiomyocytes. That also means if we can use some drugs block sodium channel, means inhibit conduction velocity, inhibit excitation of cardiomyocytes, means reduce heart rate, can use to treat tachycardia. So later, the first kind of antiarrhythmic drugs, they are sodium channel blockers. Block sodium channel, block phase 0, inhibit conduction, inhibit excitation. Phase 1, this period is phase 1. Phase 1 is the partial repolarization. Occurs when the involved sodium current is inactivated and transient voltage-sensitive outward current of potassium initiated. Here it is the phase 1 partial repolarization. And thus now, from the definition, we have known except sodium channel. In this phase 0, another major channel is the potassium channel. Potassium channel flow out. It is the major channel in phase 1. Next one is here. It is phase 2. It is phase 2. We also call phase 2 is plateau. Phase 2 results from a slow inward current of calcium and reduced outward current of potassium, releasing internal calcium couples with contraction of cardiac myocytes. And we know phase 2, plateau, this period longer than the other phase. And just now we also know in plateau phase 2, except potassium channel, another channel is calcium channel. So calcium channel and potassium channel very important in phase 2. Next phase 3. Phase 3, this period. And we call phase 3 rapid repolarization. Rapid repolarization results from an increase in outward potassium current of and inactivation of sodium and calcium channels. And phase 3, phase 0 to phase 3, we call this repolarization period. Repolarization period, the major channel is potassium channel. Potassium outward. And the potassium channel is the major channel from phase 1 to phase 2 to phase 3. The last phase, phase 4, diacetyl maintains at a constant level during diacetyl until activated by an impulse or external impulse. So that means autorhythmicity. So what's the meaning autorhythmicity? Means one action potential and then impulse, external impulse, and external stimulus, external heart rate. And we call this one heart rate. And then the other heart rate. We call this figure is the autorhythmicity. Phase 4 determine depolarization velocity, determine autorhythmicity. So do you remember you have studied physiology? Phase 4 for cardiomyocytes and autorhythmicity. Two channels very important in phase 4. One is sodium channel. So for arterial or ventricular myocytes, fast sodium channel is the major channel, determine autorhythmicity. But for sinus node myocytes, the channel is the calcium channel, and we call slow calcium channels. So from this, we know sodium channel and calcium channel determine autorhythmicity. Okay. Thus, now we review the action potential of cardiomyocytes. Includes these phases. The first one, phase 0, sodium flow in, and then phase 1, phase 2, plateau, phase 3. The major channel is potassium channel. For cardiomyocytes, and the last phase is phase 4. Phase 4 for fast cell, and the channel is the fast sodium channel. For nodular cells, the channel is slow calcium channel. So we reviewed, and now we know. For cardiomyocytes, for action potential duration, the different channels, and very important in different phase. Let's review some electrophysiological characteristics of cardiomyocytes. The first characteristics of cardiomyocytes is autorhythmicity. Thus, now we have reviewed what's the meaning of autorhythmicity. That means one action potential, external response, external stimulus, and then external action potential. Another heartbeat. We call this figure is the autorhythmicity. Repolarization velocity of phase 4 determine autorhythmicity. And just now we also reviewed in phase 4, two channels determine autorhythmicity. They are fast sodium channels, and slow calcium channels. And we also have known if we can use some sodium channel blockers or calcium channel blockers can block autorhythmicity, can inhibit external response, can reduce heart rates, can use these channels blockers to treat tachycardia. The second characteristics of cardiomyocytes is conduction. And just now we also reviewed the polarization velocity of phase 0 determine conduction. So now my question is, do you remember which channel is the major channel in phase 0? Sodium, calcium, potassium. Which channel is the major channel in phase 0? Yes, excellent. Sodium channel is the major channel in phase 0. So, means sodium channel determine conduction. That also means if we can use some drugs block sodium channels, means block, inhibit conduction, reduce heart rate, used to treat tachycardia. Okay. Next, characteristics of cardiomyocytes is ERP. The full name of ERP is effective refractory period. ERP means the time between phase 0 and sufficient recovery of sodium channels in phase 3 to permit a propagated response to external stimulus is the refractory period. So, from this sentence, we have known ERP, effective refractory period, from phase 0 to phase 3. This period, we call this ERP. Do you remember the major function of ERP? Means with stimulus, cardiomyocytes in ERP. The cardiomyocytes no response. And if after set of ERP we stimulus cardiomyocytes, will have external action potential. Stimulus cardiomyocytes will have external heart rate, and that means heart rate will be increased. That means induce arrhythmias, tachycardia. So from here, we have known from 0 to phase 3 is the ERP. And this period, external response, stimulus cardiomyocytes, no response, no heart rate. So if we can use some drugs, prolong ERP means stimulus cardiomyocytes, no response, no external heart rate, can use to treat tachycardia. So now my question is, do you remember which channel is the major channel from phase 0 to phase 3 in ERP? Which channel is the major channel? Which channel? Sodium, calcium, potassium. Yes, you are very excellent. The major channel is potassium channel. So that means if we can use some potassium channel blockers and can prolong phase 0 to phase 3, means prolong ERP and external stimulus, no external response, no external heart rate, can reduce heart rate, can use to treat tachycardia. So later, the third kind of antiarrhythmic drugs, they are potassium channel blockers. Okay, next one. The mechanisms of cardiac arrhythmias. So why the patients they are arrhythmias patients? We still unclear, maybe for these reasons. The first reason, formation of a normal. The second reason is conduction of a normal. Just now we have known the definition of arrhythmias. Formation of a normal means the abnormal automaticity. Abnormal automaticity of pacemaker. We know normal pacemaker is the sinus node. So if in atrial, in ventricular have some abnormal pacemaker will induce arrhythmias. Generation of abnormal impulse by ectopic pacemakers can induce arrhythmias. And the second mechanism is conduction abnormal. So in conduction abnormal, one definition is re-entry. So what's the meaning re-entry? In order for re-entry to occur, three conditions must coexist. An obstacle to homogeneous conduction, thus establishing a circuit around which the re-entrant wavefront can propagate. Unidirectional block at some point in the circuit, conduction must die out in one direction but continue in opposite direction. Conduction time around the circuit must be long enough so that the retrograde impulse does not enter refractory tissues as it travels around the obstacle. So from this here we can know in cardiomyocytes, and for some reason maybe cardiac endocarditis, and have this triangle, and the heart rate beat re-entry circle, so induce external stimulus induce arrhythmias. So now we review the action potential of cardiomyocytes, and we also reviewed some electrophysiological features of cardiomyocytes. So we have known the channels very important in heart rate, in action potential. So antiarrhythmic drugs mainly block these channels. So the classification of antiarrhythmic drugs includes these inhibitors. The first case, sodium channel blockers. The second case, beta receptor blockers. The third case, potassium channel blockers. And the number 4, calcium channel blockers. Next class, we will study these antiarrhythmic drugs. Okay, see you next class.